We are live, ma'am.
Okay, thank you.
Design design
Subbu sir, can we mute everybody, sir? A lot of noise, sir. Ma'am has requested.
Nisha has joined. Hi, Nisha.
Hi, ma'am. Hi, ma'am. Hi, ma'am.
Oh, see.
Hi.
Actually, can you just take a
Lakshmi is an expert at that, so I'll ask her to do it. Screenshot, ma'am. Yeah, I'll do that.
Priya, just show your face, Priya Lakshmi, so that we can take a picture. Shall we start, ma'am? Subbu, shall we start? You've muted yourself.
Yes, ma'am. We can start, ma'am.
Yeah, yes. Yeah, really very happy to welcome Dr. Revati Raj, ma'am, for this IAP PG series. Every month we are having one PG series that is on Friday, usually between 7 and 8. And mostly it is well received by the PGs. Today we have invited Dr. Revati Raj, who is a pediatric hematologist. She has been trained in UK in pediatrics and hemato-oncology and bone marrow transplantation. Madam is a consultant at Apollo Hospitals, Chennai, India, since March 2002, and she's providing comprehensive and holistic care for children with cancer and hematological disorders. Her area, special areas of interest are HSCT for thalassemia and PAD, primary immunodeficiency, childhood leukemia, and novel, a lot of cord blood transplantation. Over to Revati Raj, ma'am.
So, good evening and thank you, Dr. Lakshmi, Dr. Nisha, Dr. Subramaniam, and my friend Priya for this opportunity and IAP Chennai City branch. I had actually asked them, May 8th is World Thalassemia Day. Can we do something for thal awareness? And I'm so grateful that you gave this opportunity to talk about something that is common and we need to know about it, and there are some things that we think we know and we actually don't know. So it's good to reinforce. Can I share my screen, Dr. Lakshmi? Yeah.
Yes, ma'am. Yes, ma'am. You can.
So I thought the first half I will give an introduction on how to approach a child with anemia, which is something that all of us will see in our daily practice. Whatever branch of medicine we are doing, whether it's pediatrics, neonatology, everything, anemia is like the mirror to your face. So if the hemoglobin is down, then there's something wrong with our body. So it's always good to know what is the cause so that we can treat based on the cause. And anemia really means that your red cells or your hemoglobin is reduced, and because of that, oxygen delivery to the tissues is reduced. And the WHO has given cutoff. For example, a HB of 12 is severe anemia in a newborn baby. So for every age group up to 5 to 11, 12 to 14, and in older children, there is a cutoff, and obviously boys have a little higher cutoff of hemoglobin compared to the girl children. So in general, we have to look at the age before we say somebody is anemic. All of us know that anemia is prevalent, but the numbers are completely mind-boggling because 50% of Indian population is anemic, and predominantly you see with children. So 54%, 58% of children are anemic. So this is a huge number. So none of us can escape a diagnosis of anemia because it's a very big problem, and it's prevalent across all ages and in every state across the country. So if I see a child with pallor and I know that they're anemic, how do I work them up? In my mind, I can actually think, what is the cause of their anemia, and do my workup based on the etiology, or I can approach it from a lab perspective. What is the size of the red blood cell based on the morphology? So either which ways, what works for you, you can do. But the first step is always history taking, because we have to find out why someone is anemic. So I'd always say iron deficiency anemia is not actually a diagnosis. You have to find out why is a child iron deficient, and that is the complete diagnosis. Because if we just give them a course of iron, they're going to come back to you with the same problem a few months later. So etiology of anemia could be inadequate production, excess destruction, or blood loss. It can be acute or chronic. And so based on the history taking, I'll say, are they not making enough blood? Are they losing blood somewhere? Or are they making it well, but it's getting broken down before the 120 days that a red blood cell is supposed to live in the body? So based on this, I can make plans for how to do the lab tests. And remember that our human body is amazing. If my hemoglobin falls from 12 down to 6 within a few hours, I'll feel it immensely. I will have tachycardia, drop my blood pressure. But I can walk to a doctor's office with a hemoglobin of 1.5 if it has happened over several months to years. So we have great capacity to adapt to this lack of hemoglobin. So as I said, the anemia can be increased destruction, decreased production, or blood loss. And with every age group, it changes. For example, in a newborn baby, the commonest cause is hemolytic anemia. And if you go to a slightly older child, it will be reduced production due to iron deficiency anemia. During puberty, it could be menorrhagia. So different blood age groups, also the etiology varies. And so when I ask for a history, I want to ask, first of all, is the child's symptom only related to red blood cells, or do they have features of white blood cell and platelets? So is it an entire marrow problem? So red blood cells, obviously, we'll ask for fatigue, appetite, and exertional effort intolerance. So all of these things. Whereas white blood cell, it will be frequent in infections, fevers, joint pains, and platelets. It will be skin and mucosal bleeding. Any other systemic symptoms like reduced urine output or malabsorption? What is the diet like? And the diet history should be really, really thorough. If there is any blood loss, menorrhagia, or from GI bleed. A very important history is jaundice, because a lot of the children with hemolytic anemia may just come for workup of jaundice. And if there's gallstones or leg ulcers, it says that there must be some hemolytic anemia. Family history and which part of India they come from is very important. For example, if I see a child from Punjab with anemia, G6PD deficiency is something that I would think of because it's very common there and what medications they've been exposed to. So symptoms of anemia varies from head to foot because every part of the body needs blood circulation and any source of blood loss, and period bleeding and GI bleed is the main thing we ask for. And specifically for hemolytic anemia, it's jaundice and cola colored urine. So we could have an algorithm based on the etiology, because if I'm anemic, is it lack of production, increased destruction, or blood loss? And based on that, I can do the lab workup, or I can do the workup based on the preliminary report. What is the size of the red blood cell? Normally, the red blood cell should be between 76 to 96 femtoliter. And when the red cells are normal size, we call it normocytic. If they are bigger, it's called macrocytic. If they are smaller, it's microcytic. So I'll just go through how to do a lab approach, because if you find a child is anemic and you get the initial CBC printout, based on that, how are you going to approach? In the good old days, we used to examine a blood film and we look at the red platelets and white cells. So this is how we used to see the small lymphocyte. The nucleus of a small lymphocyte should be the size of a red blood cell. If it's smaller than that, we call it microcytic. If it's larger than that, we call it macrocytic. And the red blood cells should all look like a bunch of schoolgirls, similar size, similar shape. And they shouldn't be of different size or different shape, which is called anisocytosis and poikilocytosis. And the purple spots you see in between the red blood cells are platelets. And we should have at least 10 platelets per every high power field to know that the platelet count is normal, because each dot corresponds to 10,000 count of platelets. So from this, we've now moved to manual. From manual to automated techniques. So a CBC is fed into a machine and then we get a printout. So a red cell indices, when we read, is also a good way to look at a peripheral smear. It's equivalent to looking at a peripheral smear, because machines can give us a lot of insight into what the peripheral smear looks like, because it tells you the size and how much hemoglobin content each cell has, and it gives us in the shape of a graph, which is we call a histogram. For anemia, we have the rule of 3, because the machine counts the RBC count and times 3 is the hemoglobin. So roughly the hemoglobin should be around about 12 when we have 4 million RBCs, and hemoglobin times 3 will be the PCV or the hematocrit. So any deviation, the machine will flag it, and it will either put a plus when it's higher or a minus when it's lower, or a star simply. And then we just need to learn how to look at these stars. So this is a normal machine printout, and you can see the machine has a printout for white cell histogram, RBC histogram, and a platelet histogram, and all of the indices are there. So it's very nice to look at it, because it gives you a lot of information on why is the child anemic. So just looking at this, I can have some insight into what is the child's problem. So all 3 histograms are important. White cells, where you have the small lymphocyte graph first and the larger neutrophil graph, which are usually 50-50, the RBC histogram and the platelet histogram. This comes in the form of color if you have a fancier machine. And lab people like to have a lot of terminologies for red blood cells when the size is changed or the shape is changed. And typically we'll say that there are spherocytes when there is lack of central pallor, or there's teardrop cells, or the sickle cell, or Burr cell, or basophilic stippling. So these are some of the terminologies when the red cell size and shape are changed. So the first group of anemias, and the commonest one, are microcytic, when the MCV is low. So I thought if there are PGs, and in the chat box, you could make some of the answers. I've got some quizzes here. So 9-month-old baby is irritable, very sleepy. And when you look at the child, baby looks very pale. But there's no hepatosplenomegaly, and the baby is on bottle feed and feeds cow's milk 5 times a day. So this is the peripheral smear. Anyone wants to have a guess? What is the cause of anemia in this baby? So this is iron deficiency anemia. The reflexes seem very high. So there's anisocytosis, poikilocytosis, RBC count is low, MCV is low, and the RDW, which says that the cells are of different size says it's higher. So this is typical iron deficiency anemia, which is classic what you see. Do we need to do further tests at all? Lots of people have asked this question. We normally don't do all these extra tests, iron binding capacity, ferritin, transferrin, saturation. We can basically administer the iron and follow up because within a day or two, the child improves dramatically. And the retic peaks after 3 days, and an increase in hemoglobin is seen week after week after week. So if we follow up the response, with a reticulocyte count, if you've given the iron today in 5 to 7 days, there's a reticulocyte response, and within 2 weeks, you see a rise in hemoglobin, we're on the right track. So if I say this is not iron deficiency anemia, but this is a child with thalassemia carrier, how will you differentiate? What is the one pointer in the CBC that's going to tell you this is probably not iron deficiency, but thal carrier? Anyone wants to hazard a guess? So yeah, very good. Menzer index is a very good thing. So what we need to look at basically in the machine printout is the RBC count. So whenever somebody's hemoglobin is low, look at the MCV. MCV is low. If the RBC count is low in parallel, then it's iron deficiency, but the RBC count is normal or high. This is what we check using a Menzer index, and thalassemia carrier is one of the things we should never miss, because this one child could help prevent the birth of a next sibling who could be affected with thalassemia major. And we confirm the diagnosis by doing a HB electrophoresis where the A2 is elevated. So Menzer index for iron deficiency, as I said, response evaluation where hemoglobin increases by a gram over 2 weeks, 2 gram over 3 weeks. Check the compliance. If they're not responding, see if your diagnosis is incorrect, whether they are thal carriers or they have malabsorption or continued bleeding. So if they are not responding optimally, what is the thing that you would think of? Say you've given 4 weeks of iron and hemoglobin for this child from 7.5 is only at 7.6. So what are the things you're going to do? So what would you think of? So here we ask for the stool color. If they are taking the iron, the stool color will definitely be changed. And see if they have malabsorption, definitely need GI evaluation. We still have to think if they are taking the iron, but they are drinking their 1 liter of milk per day, because the milk reduces the digestion of iron. So, and if the baby is taking a lot of curd rice and not actually taking green vegetables or fruits and dal and things that are rich in iron. So always look at what are they taking along with the iron. And very rare to have iron refractory iron deficiency anemia in children, but we always look at the diet. Just want to spend a moment in introducing all of you to HB electrophoresis, because people think that this is only something that hematologists should look at, but it's a very simple but amazing equipment which has changed the way we look at hemoglobinopathies. So basically, when we break the red cell open, the hemoglobin comes out into the circulation, and heme is the iron part and globin is the amino acid part. So this globin chain, we let it run between the positive and negative electrode. So based on the size of the globin chain, hemoglobin A, F, S, and C come and stand in different portions of the HB electrophoresis. This is gel electrophoresis. We no longer perform this because we now have an equipment called HPLC. And here we can do 1,000 sample at a time to check for what is hemoglobin they carry. Fetal hemoglobin is the fastest, so that comes at a retention time of 1 to 2 minutes. Then we have adult hemoglobin, which comes at 2 to 3 minutes, and then hemoglobin A2. Nature always has a backup hemoglobin. So the fetal hemoglobin has to change to adult between 3 to 6 months, and it's entirely adult by 3 to 6 months. And then the backup chain is A2. So normally we have about less than 2% of F and less than 2.5% of A2, and the rest is all hemoglobin A. So this is a child who has refractory iron deficiency anemia. 3 months have been given iron, this 11-year-old girl, and this is her hemoglobin electrophoresis. What does she have? Does she have iron deficiency anemia? So this is Thal trait where A2 is elevated. So if there's one message from this talk is learn to look at your machine printout, look at the hemoglobin, look at the MCV, look at the RBC count. If the RBC count is low, it's iron deficiency anemia. RBC count is high, think of thalassemia carrier. And we don't need to put these children on long-term folic acid or anything. We just need to counsel, hey, listen, when you're thinking of pregnancy, test your partner. If both of you are carriers, you have a 25% chance of having a baby with thalassemia major. The problem in our country is such thal carrier diagnosis itself carries a stigma, and sometimes these girls don't get married. So we just have to be very delicate with and sensitive with our counseling. So this is another child who had come to us with anemia, recurrent body pain. Whenever you're looking at anemia, you need to know where in India they're coming from. And this is a child from Gujarat, anemia with splenomegaly. I always worry if there's a tinge of icterus, anemia with splenomegaly. So we looked at the family HB electrophoresis. So what do you see here in the HB electrophoresis? There's an extra band. Normally we should see F, A and A2. There's an extra band. So one parent has 37% sickle. The other parent has 36% D. And this is the child, sorry, this is a D. So the child has a hybrid of S and D. So this is hemoglobin SD. So these are what we call non-transfusion dependent thalassemia. So they present with the sickling and body ache, not that they're requiring blood transfusion every month. So this is NTDT, and they have mild to moderate severity. Whenever they are stressed, their hemoglobin goes down, including during puberty. Just want to introduce a last concept in iron deficiency anemia. This is a protein called hepcidin and ferroportin. A lot is learned about hepcidin and how it controls how much iron we digest in our body. And what we need to know is hepcidin is plays a negative role in iron digestion. So if hepcidin levels are high, we reduce iron digestion. If hepcidin levels are low, we increase iron digestion. And we know that early morning hepcidin levels are low. So nowadays, we know that if you want to give iron effectively, give it once a day or even once an alternate day. If you give iron 3 times a day, it stays in the GI tract and causes more dyspepsia and side effect. And once a day iron is very effective because early morning that hepcidin levels are low. And the last part is anemia of chronic disease. We have iron in the body, but we are not able to use it because there is a lot of TNF alpha, interleukins in the bone marrow because of a chronic infection or inflammation. And one of the main things we need to look for in our country in a child with chronic anemia are we missing TB? Are we missing infections like HIV or liver failure, rheumatological conditions? So this anemia of chronic disease is multifactorial, so look for it. So this is another quiz. A 13-year-old with severe anemia and fever, splenomegaly and icterus on examination. The clue here is a high MCV. Anyone wants to guess what is happening here? Because if you see the RBC histogram, MCV is so high. So, so this is not hereditary spherocytosis. You can see that the red cells are agglutinating. So they are sticking to each other. It's an acute anemia. So whenever the red cells are stuck to each other, the MCV appears high. So this is somebody who's had a viral infection and has developed cold agglutinins, and because of that, the red cells are sticking to each other or it can be a manifestation of warm antibodies, as you see in a child with SLE. So this is something we do to see, does the red cell have antibodies stuck on its surface? So for this test, we do something called a direct Coombs test. So if the antibodies are stuck on the surface of the red cells and we add anti-human immunoglobulin, then the red cells agglutinate. So this is called DCT. Sometimes the antibodies are free in the serum. So first we make them get stuck on top of the red cells, and then we add the anti-human immunoglobulin, and this is called indirect Coombs test. So DCT and ICT are positive in autoimmune hemolytic anemia. So this is Coombs positive autoimmune hemolytic anemia, and this was the child's first presentation of SLE. And here you would restrict transfusion and give steroids, because you use transfusion only if the child has come in frank failure. Macrocytic anemias are very rare in children, and we'll basically think of vitamin B12 and folate deficiency. So very rare to see macrocytic anemia, and they have to be malnourished or have some ileocholic junction problem. The third group, what we see, so we saw microcytic, we saw macrocytic, now normocytic, normochromic anemia. If the MCV is in the normal range, you want to know what's happening with the marrow. And reticulocyte count is an important test. Normal reticulocyte count is 1 to 2%. You have something called a corrected retic count. If the hemoglobin is dropping down to 6, then the marrow should respond if it's healthy. It has to go up, retic has to go up to 4%, 5%. With a HB of 6, if the retic count is 1%, it is not normal. So it is abnormal because the marrow is not responding. So look at the retic count. Is it low? That means there's something wrong with the marrow. It's either aplastic or something's infiltrating the marrow like a leukemia. If the retic count is high, then it could be either a blood loss or hemolysis. So this is how we look at normochromic, normocytic. So this is a retic stain, and the reticulocytes are young red cells which still have some of the RNA content. So they take up like this on a peripheral smear. All the purple dots that you see are cells with which are reticulocytes. So every 100 cell, we have to see 1 or 2 retics. So here you can see for 100 cells, there are very high numbers of retic. So this is a condition which could be either a blood loss or hemolysis. So this is what I meant about the absolute retic count. Take it in terms of the anemia. So this is the next quiz. A child who's, a child who's dropped his hemoglobin from 9.4 down to 5.8 to 2.8. And he's got low-grade fever, looks active, playful, but has cervical nodes and liver of 2 centimeters. And there's small bruises and petechiae over the legs. Over the last 2-3 weeks, you've been seeing and giving iron. So what do you think is happening here? So here they don't have the story only for the red cells. They have some stories to say there's some white cell problem because there's intermittent fever, and platelet problem because there's bruises and petechiae over the legs. So this is somebody whose marrow is not working correctly. So we have to ask for all 3 cell line histories. So we did a bone marrow. And if the bone marrow is showing all cells looking similar to each other, that is a monoclonal group of cells, it's a leukemia. So this is a child who turned out to have acute lymphoblastic leukemia, and a marrow proved the diagnosis. In a similar case, 8-year-old who had 4-week history of epistaxis, bruising, pallor, ecchymosis, but no lymph nodes or organomegaly. And you can see there is pancytopenia with a retic count of 0.2%. And in this child, we did a bone marrow biopsy. The marrow on the left is normal, and you can see the marrow on the right entirely replaced with fat. So this is severe aplastic anemia. So when you have all 3 cell lines affected and you have no nodes, no organomegaly, it's more likely to be aplastic anemia. There's nodes and there's organomegaly, more likely to be a leukemia, and we have to treat them accordingly. So anemia approach would be, what are the indices? Is it microcytic? Is it normocytic or macrocytic? If it's microcytic, think, is it iron deficiency? Is it a hemoglobinopathy, or is it anemia of chronic disease? If it's normocytic, look at the retic. Is it low or high? If it's high, think of blood loss or hemolysis. If it's low, think of chronic disease or some marrow failure infiltration. Macrocytic predominantly will be B12 or folate deficiency. So this is how you approach a child. And in summary, mainly use RBC indices to guide your tests and look at the reticulocyte count in terms of normocytic anemia. So this is the approach to anemia part. And if anyone has any questions regarding this, I'll wait for a few minutes before I move to thalassemia, because this is just an outline. And the recent IAP algorithms, Meena has done a beautiful algorithm on approach to anemia. So I'd recommend all of you have a look at it, because having these algorithms really helps us when we are in a office practice to see what should we do next.
Ma'am, Priya, here there are a few questions, maybe a couple of questions we could take
Sure.
before we move to the next section.
Sure. Please
Someone
do.
has asked, what is the normal range of RBC counts?
So the RBC count depends on whether it's male or female. Generally, it's about 4.5 to 5.5 in girls, and 5.5 to up to 6.5 in boys. So anything which is for that particular age and sex, if it's above that, then always a high RBC count, think of thalassemia carrier.
Okay. And another question is retic index used?
So the retic index is what I was trying to tell you, that you're looking at the reticulocyte count with the perspective of what is the hemoglobin. So normal reticulocyte count is 1 to 2%. So if the retic count is 1%, but the hemoglobin is 4, then that is abnormal, and that's what the retic index is trying to tell you. It is used on a daily basis, yes.
Those are the questions now, ma'am. We can probably take up again the end of the session.
Sure. Shall I move over to the thalassemia part?
Sure, ma'am.
1 second. I have to find out where it is. 1 second. So the reason why I wanted to talk about thalassemia is it looks like India is the thalassemia capital of the world. And it's a genetic blood disorder. And we as pediatricians, I think we've been talking for about 2 decades to see how can we prevent thalassemia. If we have a condition where there are 10,000 new births every year, I think we are doing something wrong, because there are so many countries that are now having effective policies to prevent thalassemia, whereas we still don't have a national policy for prevention. And these are patients, if A simple blood test could have been done during pregnancy. We could have prevented the lifelong transfusion therapy. So, chromosome 16 makes alpha globin chain, and chromosome 11 makes gamma, delta, and beta globin chain. And as I said, THAL carrier worldwide, they don't have any symptoms. And when two thalassemia carrier people are partners and there is a baby born, each pregnancy has a 25% risk of having a child who's affected. And they look normal at birth. So everyone's happy, beautiful baby. But between 3 to 6 months, when they have to change their fetal hemoglobin to adult hemoglobin, they don't have the genes that should be making this. So the prevalence worldwide mirrors that of malaria, because nature has been beautiful. And if we are THAL carriers, the red cells don't get infected with the malaria. So 3.2 to 3.6% of India's population are thalassemia carriers. And they don't have any symptoms because they have natural protection against malaria. And these are the high-risk groups in India: Sindhi, Punjabi, Gujarati, Bengali, Saurashtra. In Tamil Nadu, we have a pocket in the Nilgiri, Toda district, Ooty, Kunnur, Coimbatore, and another pocket in the Madurai area where there's a lot of Saurashtra people who come, and in the Tirunelveli district, Ramnath district, where there is high consanguinity. And so these are the risks, and it's very shameful that we still produce about 10,000 babies every year affected. This is just data from the 3.2% carrier rate. Actually, we don't have any data because a lot of these babies are lost as infant mortality. And although Cooley described anemia ages ago, we've now coming to 1938 to now, but we still don't have a prevention program. And the government has introduced this Nestrov test, which is called a naked eye single tube red cell osmotic fragility test, to look at the prevalence of thalassemia carrier. And basically, it's a very useful screening tool where an Anganwadi worker can go to a village, see using the osmotic fragility based test to see if someone's a carrier or not. But what do we do after that? It's an important way, because genetic counseling, as I said, should be handled in a sensitive manner. And if someone's a carrier, they should be told it's not a disease, it's not a disorder, but this is for their future planning. And we should be the change we wish to see in the world. It's very important to talk about this and to prevent stigma, but the more we talk, the more we can prevent. And a carrier has absolutely no symptoms. And by doing just at pregnancy, a booking pregnancy, if the obstetrician could check that they have THAL carrier indices and then check the partner, we can go a long way, because MCV is low in both iron deficiency and THAL carrier. But the RBC count is what is going to give us the clue that this could not be iron deficiency. So many of the patients that we see, the mothers have had transfusion during pregnancy, iron injections, but nobody told them or thought about THAL carrier. And the machine gives beautifully with the plus sign. You can see on the RBC count. As soon as we see this, we should know that we are not dealing with iron deficiency. And HPLC is normal in iron deficiency, whereas A2 is elevated if they are THAL carriers. 3% of THAL carriers can have normal A2. So we have to look for the indices. Sickle cell anemia is also a problem in our country, and HB electrophoresis can pick this out. Chorion villus sampling can prevent an affected baby being born in the family. And this is something we should talk to all of our families and make sure that a second birth in the same family is not happening. So just a little quiz. Is it true or false that there are 5 common genes causing thalassemia in India? Anyone wants to take up? So, yeah, Lakshmi, great. It is true. There are more than 400 different genes that cause thalassemia major, but there are 5 common genes. So that covers a lot of our population, and the 5 common gene mutations, if we take, we can easily do prenatal diagnosis in our country. And there's a lot of publications on the common THAL gene mutations. And as the NGS costs have come down, doing prenatal these days is very, very easy. However, awareness is very poor. So this was an interesting study that I wanted to share with everyone, that caretakers were questioned, why did you get thalassemia? We did the same in the patients that came to us from the Sitteri district in Dharmapuri. And they all felt that there was something wrong with the water that they were drinking, and not realizing that it is a genetic problem and it can be preventable in their next child. So this is important to keep talking. And we need to talk about this to have a thalassemia-free India, which is what we are hoping for. And this small group here, if you can go and give the message to others, it will definitely have a ripple effect. So we have to keep talking so that we have guidelines for screening, diagnosis, and management. We have IEP guidelines now, but we need governmental policies for prevention. Once they're diagnosed, what should we do? We have to counsel them to keep hemoglobin above 9 grams, use screen blood, and always remember not to allow the parents to donate for their child. Immediate family members to donate for their child. This is very, very important so that it's not causing problems to the child. Iron causes toxicity. Every bag of blood has 200 milligrams of iron, and this can cause toxicity to the heart and to the liver. So it's very important to prevent organal damage, because this because of iron, they can have liver and cardiac damage. So patients have monthly transfusion, and to prevent iron overload, previously we had only injectable chelators, desferrioxamine. Now, thankfully, the last decade and a half, we have the oral chelators. But how do we use them? So you have desferrioxamine, deferriprone, and deferasirox. So how do we use them? The gold standard drug is desferrioxamine, but it's an injectable form. It gets excreted immediately. So it has to be done as a slow infusion through a pump. And I'm happy to say that India now has its own thalassemia pump. And before, we had to import it from Greece. So we now make in India. So this is one drug which is very effective. The second one is deferasirox, and the main advantage is it can be taken orally. So it's once a day on an empty stomach. Remember to tell your patients to use a glass tumbler, not an Eversilver, because it sticks to Eversilver. And it has to be dissolved in the water or orange juice that the child drinks. And it's very effective to remove liver iron. Deferriprone was the first oral iron chelator. The main thing is it has a short half-life. So it has to be given over 3 times a day. And it's a very effective drug for removing heart iron, but it only is about 30% potency of desferrioxamine. So we now have ways of combining these drugs. I don't want to have injections every day. I don't want to take tablet on an empty stomach because it causes gastritis. So they can work well, especially deferasirox and deferriprone, because it brings out the intracellular iron into the blood, and then that can be made water soluble, and they work very well effectively. So I just wanted to share over years the experience at our thalassemia center and how we've used chelation. We start at the age of 2 years or older, because if you start at less than 18 months, these chelators can cause joint damage. And once the ferritin is above 1,000, and the dose should be tailored. We now have access to cardiac MRI, beautiful tool, because inside what's happening, what's causing the iron to increase, we can see in the liver and in the heart. Whenever you see a sudden jump in ferritin, remember ferritin is a acute phase protein. So it could be that there is hepatitis C or some infection in the child's body. So we monitor cardiac MRI in the above 8-year-olds. We don't do liver biopsies to look at liver iron. And the combination chelation really works. Sometimes they are in a hurry to go to school. They can't take the deferasirox on an empty stomach in the morning. So we've got the 4 p.m. deferasirox, which helps. And then they can have some deferiprone at night. So these combination chelation has helped prevent the endocrine complications of hypothyroidism, growth retardation, delayed puberty, diabetes, osteoporosis. Bone disease is a big problem in adult thalassemia. And they have cardiac camps every now and then because cardiac complication of iron overload is a big problem, especially those who've had a splenectomy. And our study revealed that definitely ferritin is not a good marker on its own. We need ferritin, we need cardiac MRI, and we need a good echo. And all of these combined together, when the heart doesn't relax on the cardiac MRI, then we are in big trouble because those who had low ferritin also had problems with the heart. So we need everything combined. So cardiac iron, if we measure and show the patients, chelation compliance also improves. So one little quiz here. Non-transfusion dependent thalassemia do not have iron overload. Anyone wants to answer? NTDT. They don't have transfusion. So do they suffer from iron overload? So this is false because you're all absolutely right because those who have never had a transfusion can still have tissue iron overload because the body is absorbing too much of the iron. So normally we only absorb 10% iron, but in NTDT they absorb a lot and they can have a problem. Hepatitis B, universal vaccination has prevented hepatitis B infection due to blood, but HCV is a big problem. So now that we have a good anti-hepatitis C virus medications, this is coming down with time. We're certainly seeing a downward trend over the last 5 years. A big problem is alloimmunization. If they are not well cross-matched, then they develop antibodies and the next time they do not respond and then the spleen enlarges. So 7% of our patients have alloimmunization. So this is one of the babies born to our Thal major patient. And this has been possible only because they learn to run a marathon every day, be consistent with transfusion, be consistent with chelation. But then some are lucky enough to have a transplant. So there are more than 100 centers which do transplant now. So really request people to refer patients of thalassemia for transplant because transplant advances have become really good. And we want to talk about patient selection. This graph shows beautifully that those who are transplanted less than 7 years do better than those who are transplanted above 7 years. And once their liver enlarges and they have iron overload, they are called class 3 thalassemia. And their outcomes are really poor compared to the clean thalassemia patients. A donor is important. So sometimes when it's a single child, we think they don't have a donor, so we'll refer later. But we have matched sibling, or we can have 30% of our patients have a matched sibling. Some of them have gone on to have PGD to have a savior sibling. And for those who don't have a family match, 30% of our patients, we can do a worldwide search and get an unrelated donor. Another 40% and family and unrelated donor outcomes are really good with over 90% survival these days. And for those who don't have an unrelated match donor, a half-match parent or a half-match sibling is also possible these days, which is called haploidentical transplantation, which also has really good outcomes. So every child has a donor. The conditioning drugs, chemotherapy that we give to these patients have also improved. So we have new drug, which is non-hepatotoxic, which helps patients have an intact survival. So triosulfan is the drug that we use. And then we take the stem cells from the donor in much easier ways. Rather than take from the bone marrow, we are able to take from the blood. And then after infusing these cells, It takes about 2 weeks for these cells to grow in the child's body, and they are looked after in a sterile environment for these 2 weeks, protected from infections, and they need to be on immunosuppression for about a year. The beauty of bone marrow transplant compared to solid organ transplant is they are on immunosuppression only for about a year, and they shouldn't have rejection or graft versus host disease. So rejection is a problem in about 5% of our patients, and follow-up care, we need the help of pediatricians. So this is the story of a little girl who post-transplant developed dengue and encephalopathy, and they were looked after by their primary pediatrician in a small village until our ambulance could go there and pick her up, intubate, ventilate, and then she went on to celebrate Diwali. So it's a very important part of teamwork until their immune system goes back to normal. All the things we do to these children, we have to follow up what effect it has on their fertility. We did a quality of life study on should we have transfusion or chelation. And then you see that the transfusion group, the quality of life was far poorer compared to the transplant group, 92 points versus 83 points. And as they grew older, the quality of life score got lower. So transplant scores over this. And everyone says the cost of transplant is high, but the background cost of transfusing and chelating a patient lifelong far outweighs the cost of one transplantation, especially in Tamil Nadu, where it's covered through CM scheme. I think every child deserves a referral for transplant. So transfusion group also had cardiac iron overload, hepatitis C, alloimmunization, endocrine problems. So the overall survival is good, over 80 to 85% in any kind of transplant. The future, what is now coming, is gene therapy. So rather than have a different donor, take the child's own stem cells, introduce the missing gene, and put it back into the child. So this is like an autologous transplant. So gene therapy is now licensed in the world, but it now costs over 2 crores. So we are waiting for our own indigenous gene therapy to happen in India. Make in India will reduce costs, because once gene therapy comes, we have access to cure for a lot of inborn errors of the blood. And the future is bright, and I really am grateful to IAP Chennai City branch for giving me this opportunity to share what are the advances in the world of thalassemia. Thank you so much. I'm happy to answer any questions.
Thank you so much, ma'am. 130 participants have been benefited by your talk, madam. It's usually on a weekday between 7 and 8. It is really a very nice, madam. It was very nice. My only one question, we follow with the other questions later. This is a non-life-threatening condition. So BMT, we are referring and all that. Is the death or mortality have you ever encountered following a BMT in a thalassemia patient?
It's a very valid question. So when we are doing transplant counseling, these are the things that we have to have data. That's why I showed you the quality of life data from the transfusion group and chelation group. And your question about non-life threatening is really valid. And I find over 20 years, counseling a thalassemia patient for transplant is the most challenging, because each person has to make their own decision. So if as pediatricians, you're not seeing all the morbidity, because it happens over time in their 20s, in their 30s, and in their 40s. So the patients who've had early transplant have really benefited from the procedure compared to those who have been on long-term transfusion. Usually we find the referral happens when they are moving from their pediatric to the adult colleagues, because, oh my God, I've been under the pediatrician, I've been looked after like I've been in a home, but then they have to go out of the pediatric care. That's when we get referral, and by then they're already what we call high-risk thalassemia. But if they are done earlier, mortality is lower. So the mortality varies whether if it's sibling allograft, unrelated or haplo. The older they are, and if they have a haplo transplant, we do see 5 to 10% mortality. But as I showed data, that when we are using the triosulfan-based protocol, 80 to 85% patients are cured and thalassemia-free. So the decision that the family has to make is, are they willing to take the 5 to 10% mortality risk or not? And we are very clear and honest with our counseling.
Cord cell transplantation, any particular advantage apart from the cost?
Up until 2012, we were the biggest users of cord, but after 2012, we have stopped the cord transplant program because cord has 1 log lower stem cells. So it takes about 28 to 35 days for the new cells to join in the child's body. You can imagine in this day of multi-drug resistant bacterial infection, if someone's sitting in our unit with a WBC count of 0 for 35 days, we don't have antibiotics to match the bacteria for 4 to 5 weeks. So we have moved over entirely from cord to haploidentical transplant for most of our patients.
Thank you.
And we are not recommending cord storage also.
Priya?
Ma'am, there's questions in the chat box. So someone has asked difference between corrected retic count and retic index.
Okay, so this is too technical, and I will, if you give me their number, I will directly message. The corrected reticulocyte count is the retic count corrected for the anemia. Retic index is telling how many immature versus mature retics are there, and it tells you how much the marrow is performing. So I think these are things I don't use on a daily basis. I just look at what is the retic count compared to the degree of anemia. So I think if we keep life simple, it will be better.
The next question is prenatal diagnosis available in all cities in Tamil Nadu?
So absolutely, yes. Again, as I said, access to care is much better now compared to before. If you have any underprivileged family that needs prenatal diagnosis for thalassemia, please feel free to refer to the VHS Thalassemia Center, and we have a sponsorship program because it's our aim must be for prevention. And extended family, we tell everyone, the mothers, brothers, sisters, fathers, brothers, sister, everyone to check for thalassemia before they plan pregnancy. And the ideal age for transplant is less than 7 years, because after 7 years, the liver and heart get chock-a-block with iron, so the mortality increases. So the younger they are, the better.
And the cost of bone marrow transplant, ma'am, that is one of the questions.
Sure. So if you have a fully matched sibling, then the cost of transplant is anywhere between 12 to 15 lakhs. And if you have an alternate donor, which is an unrelated or half match, the cost is double. And the older you are, because all the drugs are per kg body weight. So for a 15 kg child, if the conditioning drugs, triosulfan, thiotepa are all going to cost about 4 lakhs, then if it's a 30 kg child, it will be 8 lakhs. So everything is dependent on what is the age. So that's why we say the younger they are, the better. There's also a question on super transfusion, hyper transfusion. So we use these regimens only if the child has presented with a big spleen. See, when they are chronically under transfused, the marrow expands, you have extramedullary hematopoiesis and the spleen enlarges. So if I want to reduce the size of the spleen for someone who's been under transfused for several years, then I aim for a hemoglobin of 10 or 12, which is what is called hypertransfusion or super transfusion. Generally, for a routine thal patient, we aim for a hemoglobin of 9 before transfusion, because that is enough to reduce and prevent splenomegaly. The spleen tells us the story of their transfusion, and the liver tells us the story of chelation. So anyone who has enlarged liver has had bad chelation, enlarged spleen has had suboptimal transfusion.
That was very nice to understand, ma'am. And another question is ideal age at which transplant can be considered.
So all studies have said less than 7 years. So the earlier, the better. So we usually start counseling families even at the first diagnosis counseling.
Anywhere, gene therapy has already been done, madam.
Yeah, so there are successful gene therapy patients all abroad actually from Greece, Cyprus, from the US. So we have a lot of success stories. The vector, so you have to have a lentiviral vector which carries the gene and puts it into the stem cell. So these vectors are the costly part. So if we can have an indigenous vector, then we can reduce the cost, and several groups in our country are working on indigenous vectors. So hopefully something will click.
Brahmani would like to offer a vote of thanks. Shall we now close the session, madam? You're on time. Thank you so much. It was an excellent session, madam. I really enjoyed.
Thanks.
Thank you so much, ma'am. Though we all
So also
go
me.
through
Thank you.
Yes, thank you, sir.
Sir, senior most pediatrician, madam. Our Pitamahar of pediatrics has joined us, and KG Kamla, madam, was a director of ICH Longback. She has also joined. Many people,
Thanks.
PGs, is our faculty.
We are not able to see KG Kamala.
Yes, Subbu.
Thank you. Thank you, Dr. Edraj. It was indeed a good, look back at thalassemia. I remember attending your class on thalassemia as a postgraduate. I came all the way from Bangalore to attend the class as a postgraduate, and it's really a good, refreshment for me to go through whatever. Then we had only subcutaneous infusions, and now things have moved forward a lot, and I can see how we are talking about gene therapy and other things. And I really thank you for giving us this talk. Many of us have got an awareness and its importance of early referral for bone marrow transplant and antenatal diagnosis. Both are probably the most important takeaway message. I thank our President, Dr. Lakshmi, for envisaging this talk, and I would like to thank Priyavardhini ma'am for coordinating the whole thing, Nisha ma'am, and rest of the IAPCCB team for helping us through. I would thank everybody who has joined us today evening, towards the late evening, for this talk and encouraging us to do more such ones. Thank you all. Have a great day.
Thank you, madam. Thank
Thank
you.
you, madam.
We will call you for more talks.
Thank you all.
Thank you,
Thank you.
Srinivasan sir, for being with us. Thank you, sir.
And would like to tell that this meeting is live streamed in
Live
YouTube.
stream
So
YouTube.
recording will be in YouTube, ma'am. Others also have not been able to
We
attend,
can watch
can
you.
go through it.